Hello, and welcome to the Parkinson 101, What You and Your Family Should Know. I'm Jenny Fearday, a Community Engagement Manager for the Parkinson's Foundation. Helping me behind the scenes are my colleagues, Erin McGee and Elizabeth Guerrero. Erin, Elizabeth, and I warmly welcome you to the webinar today, especially anyone joining us for the first time. Please note, we are recording today's presentation, and you will receive a follow-up email from us with a link to today's recording and slides. We would like to know who is joining us today. Please take a moment to share your connection to Parkinson's disease in the chat button. As we begin, we want to welcome you and take a moment to share the mission of the Parkinson's Foundation. Every day and everything we do, we are working to make life better for people with Parkinson's. To achieve our mission, we pursue three goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global community. Today's program is a great example of one of those things we are doing to help us meet these goals. One example of our mission in action is PD generation. This research offers genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost. Commit to helping us advance Parkinson's research today. Check your eligibility and enroll now to be part of PD generation at parkinson.org/PD generation. We want to hear from you. Parkinson's Foundation surveys periodically ask people with PD, their care partners, and medical professionals about specific aspects of living with and treating Parkinson's. By better understanding how people living with PD experience the disease, the Foundation can be better informed in its programming, research, grant funding, and policy initiatives. Please watch for a survey at the end of our program, and you'll also receive it in a follow-up email. I'd like to take a moment to recognize that PD Health at Home is presented by Light of Day Foundation, whose generosity has made this programming possible. The Parkinson's Foundation has been providing weekly educational and wellness programs virtually through our PD Health at Home series, including Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. As a reminder, all programs are held at the same time, 1 p.m. Eastern Standard Time. You can learn more and register for these programs by visiting parkinson.org/PD Health. I am now pleased to introduce our speaker for today, Dr. Kelvin Au. Dr. Au is a clinical assistant professor in the Movement Disorders Division of Neurology at the University of Kansas Medical Center, graduated from the University of Manitoba Faculty of Medicine in Winnipeg, Manitoba, Canada, and completed neurology residency at the University of Calgary in Calgary, Alberta, Canada. Completed a 2-year movement disorders fellowship at the University of Florida in Gainesville, Florida, under Dr. Michael Okun and Dr. Christopher Hess. He is certified by the Royal College of Physicians and Surgeons of Canada, Neurology. His interests include clinical trials for various movement disorders, deep brain stimulation, botulinum toxin therapy for various forms of dystonia. He has published articles relating to DBS and movement disorders and has a research interest in multidisciplinary care in Parkinson's disease. Welcome, Dr. Au.
Thank you for that introduction. It's a pleasure to be here. I'm just going to try to start sharing my screen. I think you have to, there you go, perfect. Let me just get my screen sharing going. But yeah, it's a pleasure to be here. I see that people have kind of commented in the chat kind of where they're at, or kind of, you know, it's their first meeting. Many of you people have often been just, some people have just been diagnosed. So it's great to have you here, so welcome. All right, so PD 101, Parkinson's disease 101, what you and your family should know. We're going to talk about a bit of an overview of some of the initial questions that you might have if you were just initially diagnosed, or if you've had Parkinson's disease for 10 years, things are rapidly evolving in the field, and kind of things to kind of look out for, and which is always kind of exciting. We'll talk about some of the causes of Parkinson's disease, some of the symptoms to look out for, because it may not just be one symptom. There's actually a lot of things that Parkinson's disease can involve in your body, how to manage those symptoms, and we'll touch at the end some of the potential research opportunities that you can get involved in. What is Parkinson's disease? It's what we call a neurodegenerative condition. It is a progressive brain disorder, meaning that it's a problem with your brain causing you to have abnormal movements. It is expected to progress or worsen gradually over time. At present time, there is no cure, unfortunately, but we can do our best there's many different medications and treatments available to help manage the symptoms so that people can still live the best quality of life that they want to for a long time. Parkinson's disease can affect your movement, but also other things that you may not think about, including mood and thinking, memory and cognitive abilities. Although there is no cure, a healthy lifestyle can certainly help. We'll talk a little bit about exercise a little bit later, but that can certainly help with the symptoms and maintain a quality of life. So we say that when people come into the clinic and they are first diagnosed with Parkinson's disease, they often ask, how long will this progress, or how quickly will it progress? We often say that on average, many people do quite well for decades, 10, 15, 20 years, if they're able to kind of combine that with good management, with connecting with the right healthcare professionals, but also taking care of themselves with regular exercise and a healthy lifestyle. And that's part of the reason why you're here. You're looking to get plugged in, kind of getting into the right resources. The Parkinson's Foundation obviously has a lot of good educational seminars like this one, and also resources online to help you understand what Parkinson's disease is for you or your loved one, and to know what you can do to help manage the symptoms. About 1 million people in the United States have Parkinson's disease, and that's unfortunately rapidly growing. There's been some people that even call it a pandemic, a Parkinson's pandemic, in that, and we're all familiar with that in the past couple of years, but in the sense of it's a lot of people in many geographical areas having and obtaining Parkinson's disease, and that number is growing, and we see that in the clinics. It can affect anybody. It affects all races, ethnicities, and gender. Most people are diagnosed in the 6th or 7th decade of life, although there are forms of Parkinson's that are what we would call young onset Parkinson's disease. And I see that some of you in the chat fit this category, that where you're less than 50, you would be a young onset Parkinson's disease, but there's people even in their 30s and even in their 20s that can be diagnosed with Parkinson's disease. We don't know the exact cause of Parkinson's disease, but we think that there may be a variety of different factors involved. About 10 to 15% of people have a genetic form of Parkinson's disease, where we can, through genetic testing, find a specific genetic mutation that causes the Parkinson's disease. And often those individuals have a family history of Parkinson's disease, but not always. And then we have increasing evidence that there's certain environmental exposure, certain pesticides, paraquat, and other things that are used that may increase the risk of Parkinson's disease. And then other potential risk factors include just being older. As you get older, there's a higher chance of getting Parkinson's disease, but also things like traumatic brain injury. But there's no one thing that we've identified that causes all different types of Parkinson's disease. Many times it's unknown after we do, say, some of the genetic testing and look for other potential exposures, but sometimes it's hard to pin down. And the majority of people, like I said, 85% of people we say have Parkinson's disease, and we don't know the specific cause. Parkinson's disease is a disorder of the brain. There are cells, to get into the nitty-gritty details, there are cells in your brain that produce a neurotransmitter called dopamine. And dopamine is something that, when released, helps with normal movement. When you have a lack of dopamine, you can have difficulties with coordination of movement, difficulties with fine motor tasks. Your speech can be a little bit softer and more difficult to produce and project your voice. But dopamine is also a part of your reward system, and that can play a big role in mood, cognition, as well as sleep too. And it's not just dopamine that's lost in the brain. There's other neurotransmitters such as serotonin and acetylcholine that are also lost in Parkinson's disease as well, which contributes to the symptoms. So many people are looking at this at kind of the cellular level, looking to see if there are ways to see if we can stop the destruction of these cells that produce dopamine, the dopamine producing cells, or at least slow it down. So what should you know about the symptoms? It affects many systems. As I mentioned, there are motor symptoms or movement. It's called a movement disorder. That's the broad field that Parkinson's fits under. There are tremors, which some of you may have or know somebody that has tremors, but also slowness and stiffness as the initial symptoms and what people with Parkinson's disease have. But the symptoms can vary from person to person. It's very individualized. As you hear some of these seminars, and even today, you may hear about a variety of different symptoms, which may or may not necessarily occur for you. Sometimes people get overwhelmed when they say, oh, look, Parkinson's disease can affect all these systems. Is that going to happen to me? It's, you know, in clinic, I respond and say, not necessarily, but we'll take it as it comes if it does, and just to know what things to look out for. We'll start with the motor symptoms. The most potentially most recognizable one is the tremor, because that's visible to not just the individual, but also those around them. The people with Parkinson's disease often describe an internal sensation of tremor where visibly or outside, they cannot see the tremor, but they get a sense of shaking. And often that's how it starts. But then eventually it kind of progresses to the point where you can see some of the tremor. It is often a rest tremor in the hand, but it can be in the foot and the jaw. And when I say rest tremor, I mean when you're sitting down, for example, sitting there watching the couch, and just when your arms are kind of seated at rest on the couch, or when you're trying to go to bed, often that's when the Parkinson's resting tremor is most prominent, as opposed to when you bring up your arms to do things. That's a different type of tremor, but you can have it. You can also have that in Parkinson's disease as well, but it's not as common. There are some people, as noted in this slide, that don't have a tremor that can have Parkinson's disease as well. So going back to the point where you may read about all the different symptoms of Parkinson's disease, but you as an individual with Parkinson's or your family member with Parkinson's may not develop all of the symptoms as well. And that doesn't necessarily mean it's not Parkinson's disease. You can have slowness in, with your movements, difficulties initiating movement. The medical term for that is bradykinesia. And then you can also have stiffness or rigidity, particularly in your arms and legs and neck and hips. Sometimes that can be hard to tease out as you get older, of course. Some people report you get arthritis and back issues and knee issues, and people often are stiffer as they get older, and they wake up in the morning and they feel a bit stiff. But this would be something on top of that. And I understand that sometimes that's hard to tease out, whether the stiffness is coming from the joints or the muscles. But in Parkinson's, it's more the muscles that are stiff and rigid that causes that. And then problems with walking and balance and difficulties with kind of shuffling their feet or dragging their leg is sometimes what people report in Parkinson's disease, especially early on. Apart from the non-motor, apart from the motor, there's what we call non-motor symptoms, or what we would say non-movement symptoms. Often the motor symptoms are just the tip of the iceberg, and the Parkinson's actually can affect many different systems in the body. It can affect your mood and your mental health. Up to 50 to 60% of people with Parkinson's disease can have depression and anxiety. Like I said, dopamine is part of your reward system, but there's other neurotransmitters that are lost, and that can lead to difficulties with mood and anxiety and irritability. Apathy can be something that is experienced where you're not necessarily depressed, you're not feeling sad, but people with Parkinson's can just report that, they're just okay with just kind of, sitting watching TV, whereas previously they may have been the person to kind of initiate the conversation or plan things on the weekend. That might be diminished as Parkinson's progresses. Thinking and memory, cognition, often difficulties paying attention, learning new things, often multitasking can be challenging. And then sometimes memory, specifically with word finding difficulties, if they sometimes catch themselves kind of in the middle of a sentence, just trying to find the right word, and then it can be challenging to come up with it. But sometimes this can be hard to tease out between normal aging. As Parkinson's as you get older, you can also have some of these symptoms where you're just a little bit forgetful, but your neurologist can kind of help guide you through that process in determining whether this is from Parkinson's or from normal aging. And there's different tests, cognitive tests that we can do to kind of help distinguish that. And not just, apart from mood and cognition, there's other things too. You can have speech difficulties. Sleep is a big difficulty, and fatigue in Parkinson's disease. There's a condition called REM sleep behavior disorder. Rapid eye movement sleep, or REM sleep, is a stage of sleep. And sometimes people can have even acting out of their dreams at night. That's a condition that is very much linked and associated with Parkinson's disease that we often come across. And until they come into the Parkinson's clinic, often people don't realize that that's one of, in some people, some of the early symptoms of Parkinson's disease, even before they develop the tremor or some of the other movement difficulties like slowness and stiffness. It can affect your bowels and your bladder. You can have urinary frequency, meaning you're going to the restroom really often, or urgency, feeling like you need to go right away, and as well as affecting your bowels, having constipation. And sometimes that can be years before the other symptoms develop. Sometimes people have hallucinations as well, where they're seeing things or hearing things that other people don't hear or see. But like I said, these are just some things to potentially mention to your physician if you may be experiencing some of this, and seeing if it's related to the Parkinson's, but it doesn't necessarily mean that you'll develop all of these symptoms. Here are some of the 10 early signs of Parkinson's disease. Often these are things that people recognize, the tremor being kind of the most common one that people know and to associate with the Parkinson's, but other ones that, until people are, either they have Parkinson's disease themselves, or unless they have somebody that they know to have Parkinson's disease, they wouldn't have thought of it to be something related to Parkinson's disease. You can have smaller handwriting. Often you start off big and then you kind of trail off. Loss of smell. This one's a bit challenging in the past couple of years because often people had, with COVID-19, you can get loss of smell, but this is, so teasing that out is sometimes challenging, but with the Parkinson's loss of smell, often it's kind of a gradual progression over time, even up to years, just gradually losing their sense of smell, and their sense of taste can be altered as well. And then you can read the other ones here, just trouble moving or walking, sleeping, constipation. Some of these we've kind of touched upon. The dizziness or fainting is when you get up from a seated position or a lying position quickly, that you feel a bit lightheaded. That can potentially be an early sign of Parkinson's disease, but it's best to just ask your physician about this. The masked face, I'll explain that one before moving on, is just that, people often have this kind of blank stare. They're not moving their facial muscles as much as they were previously. In Parkinson's, often everything kind of slows down in terms of just their overall slowness in movements, and therefore the face they may not be blinking as much. They often are expressionless, even though they actually may be feeling emotion. Their partners or their loved ones are kind of report like, yeah, in the past year, he doesn't seem to be as animated as before. That's what that is in terms of the masked face as an early sign of Parkinson's. How do we diagnose Parkinson's disease? Now this, Parkinson's disease remains what's called a clinical diagnosis. So what that is based on is we listen to the patient that comes in. The person tells us kind of when the symptoms started. We get the history, and then we do our physical exam in person, looking for those signs, looking for a tremor, looking for slowness and stiffness, and watching them walk. And if it all seems to fit within what is expected and what's typical for Parkinson's disease, that's how we make the diagnosis of Parkinson's disease. We use different assessments like what's called the UPDRS, or the Unified Parkinson's Disease Rating Scale, to kind of get an objective measure of some of the symptoms that you're having. The stiffness, we feel your muscle tone. We look at your movements with doing tests like the finger tapping or opening and closing your hand. And then we often start a medication or several different medications and we reassess you in a couple of months after you've started the medication. And if there is a response, that's more likely to be Parkinson's disease compared to some of these there's other conditions that can cause similar symptoms to Parkinson's disease. There's other conditions that can cause the tremor, slowness, and stiffness, but they wouldn't necessarily respond to the Parkinson's medications. So it doesn't necessarily, the Parkinson's medications don't make the diagnosis, but it definitely supports the diagnosis if everything else kind of seems to be lining up with what is expected in Parkinson's disease and the progression and the rate of progression. And this is done under the care of a neurologist who would be trained to make the diagnosis of Parkinson's disease. You may have come across a neuroimaging scan or a nuclear medicine scan called the DAT scan. The DAT stands for dopamine transporter. It's looking at your brain. It's not quite like a CAT scan or an MRI. It's a little bit different, but it looks at the transportation of what's called dopamine, the neurotransmitter that's involved in Parkinson's disease. And if that is abnormal, that would be consistent with Parkinson's disease, whereas in individuals who don't have Parkinson's disease, it would be normal. So the DAT scan is abnormal in Parkinson's disease, and that's another test that we can do to help with the diagnosis, but it is usually not necessary because often with the clinical history, the story, and the physical examination, often your neurologist can just make the diagnosis without having to order the scan. And usually those are just reserved for scenarios where things aren't progressing as we expect. So you've heard those 4 words from your neurologist, or with the 4 words being you have Parkinson's disease. Often the next question that follows that is, well, what can we do? How can we treat the symptoms, and when to start the treatment? I agree with the statement here that the decision when to start the treatment is made through discussion between your neurologist and the individual. Right now, as I mentioned, we don't have a cure for Parkinson's disease, but we do have symptoms to help with, we do have treatments to help with the symptoms. And it depends on whether the symptoms are affecting your quality of life. There are some people with very mild Parkinson's disease that have a little bit of slowness and stiffness and perhaps a little bit of resting tremor, where they're actually still able to manage their daily life. They're still able to work. They're still able to participate in their hobbies, their sporting events without any issues, but they have the diagnosis of Parkinson's disease. And in some cases, we often just say, hey, look, you're doing okay. You don't necessarily need to start the medication right away. But only when it becomes an issue in terms of, yes, I feel more slowness and stiffness because Parkinson's progresses over time, then we can do a trial of starting the medication. And more often than not, individuals feel much better on the medications when they have Parkinson's disease and they're started on treatment. And they often sometimes even wonder, I should have started sooner because then I could have better control of, my movements, less tremor. But each person's a little bit different in terms of when to start the medication. So that should be a discussion between the neurologist and the individual and what symptoms they're having as well. So when you do have Parkinson's disease, we would suggest getting input from a variety of different specialists. I mean, of course, there's a neurologist. The ones the type of neurologist that looks at Parkinson's specifically is what's called a movement disorder neurologist or movement disorder specialist. That's somebody who went through neurology training, but then went and did further training in movement disorders with a fellowship. But if you remember all the symptoms that I listed for Parkinson's disease, a lot of the non-motor symptoms, there's a lot of different systems in the body that are affected that, you know, the neurologist or the movement disorder specialist would often kind of refer you to help get their input on. And these include, of course, you have a general neurologist as well. If for some people that may not have access to or maybe far away from somebody that has movement disorders training. You have your nurse, your physical therapist, occupational therapist, speech language pathologist. All of these are very helpful in addressing certain aspects of Parkinson's disease that perhaps the movement disorders neurologist may not be able to from their level of expertise and time. A social worker can be helpful, as well as the psychiatrist and psychologist for some of the mood symptoms. And the pharmacist, you know, there's a pharmacist attached to our clinic. She's been invaluable to help with sorting out all the different medications that can come with Parkinson's disease. So this is the healthcare team in the center. I like to say that this is the person with Parkinson's. And each of the specialties, this is by no means an exhaustive list because there's many different specialists that aren't included here, but the specialists and different specialties should essentially kind of revolve around the person with Parkinson's. And you can ask your neurologist. Often, you know, people with Parkinson's have a neurologist that can help you find individuals from each of these categories, if needed, if that's what they feel is indicated in your situation, with Parkinson's expertise. Like, just like there's physicians that specialize in Parkinson's, just like there are neurologists that specialize in Parkinson's, there are different, for example, neuro-trained physical therapists that may have a bend or have more experience with Parkinson's, and that's what we would suggest ideally for people with Parkinson's. The first step is, you know, finding the right doctor, qualified physician. In the early stages, you know, my opinion is that everybody with Parkinson's should have a neurologist and ideally potentially a movement disorder specialist. Through the Parkinson's Foundation, there are many sites across the world that are designated Parkinson's Foundation Centers of Excellence, where there are movement disorder specialists. So you can kind of look at this phone number here or go to the Parkinson's Foundation website to look for that if you're not sure exactly where to start, but also your primary care as well as a local neurologist should be able to help direct you as well to finding a movement disorder specialist. Managing the symptoms includes things like medications, but there's also some surgical treatments as well. The medications can be for both the motor and the non-motor symptoms that we discussed. And then there's surgical options for more of the motor symptoms as well. And then outside of things that involve medications or surgery, there's lifestyle changes, especially exercise, and then different therapies who are, I would say, in some cases, underutilized because they're very helpful. And patients that I've sent to physical therapy, occupational therapy, and speech therapy are often quite grateful and find that very helpful, as well as counseling and therapy, because the mood aspect of Parkinson's is very important and shouldn't be overlooked. And even just kind of in the early stages, in the first couple of weeks to months of after getting diagnosed, it can be a little bit overwhelming, all the information, and just trying to cope with the changes that you're experiencing, and just also coping with grappling the diagnosis. That is something that we understand can be difficult, not just for the person with Parkinson's, but also for the family members and their loved ones and the people around them. Because what you had originally thought your life potentially would be, you know, thinking ahead 5 years, 10 years from now, maybe look quite different after having a diagnosis of Parkinson's disease. So we're here, or your neurologist or your team or your Parkinson's Center Foundation of Parkinson's Foundation Center of Excellence is here to kind of help you navigate the early stages and also the middle stages and the late stages of Parkinson's. there's several different medications. It can be, there's several different classes. There's several medications within each class. But here are some of the big categories. The Parkinson's Foundation has this medication booklet, or it's available online as well, that you can kind of peruse through. It gives you more information. But the biggest one is levodopa. Levodopa is what we would say is the gold standard treatment for Parkinson's disease. The levodopa is the precursor to dopamine, meaning that when you give and take levodopa, it gets converted to dopamine in the brain. And if you remember, dopamine is the neurotransmitter that's lost in Parkinson's disease. So we're essentially replacing the neurotransmitter that the Parkinson's brain isn't able to produce, so that we can help with the symptoms of Parkinson's, the movement symptoms. Dopamine agonists, this is another class. It works very similarly to dopamine. It's like almost like a synthetic form of a molecule that kind of looks like dopamine, and it binds to the same receptor. It essentially works and kind of works on the same pathways that the levodopa does. And that's something as an option we sometimes use in our Parkinson's patient. There's something called a MAO-B inhibitor. You don't need to know the name, but it's a monoamine oxidase B, type B inhibitor. It blocks the breakdown of dopamine in the brain. And if dopamine isn't broken down, there's more available to help with the symptoms, and similar to the COMT inhibitors, which also prevent the breakdown of the levodopa and dopamine, so that more is available. And often the COMT inhibitors are taken together with the levodopa to help increase the benefit of the levodopa. Whether or not these medications are suitable for you in your situation, I think you should ask your neurologist. When we use each of these is different depending on what symptoms the individual is having. But it's always it's never wrong. I never, as a neurologist, people come in and they've read this pamphlet and they say, what about this medication? I've heard about this. And I encourage those types of questions, because that means that they're engaged in trying to look for and review some of the latest medications. And I can either explain, that's something that I've thought about, I just haven't mentioned it to you, but that's something we can try in the future. Or yes, actually, that would be something that we can try today to help with this symptom that you're having. So there are surgical options, and these are kind of reserved for specific situations. You may have heard of deep brain stimulation for Parkinson's disease. It's something that is done at many centers across the United States, and thousands of people have had it. It's been around for more than 30 years. What it involves is it takes us, the neurosurgeons, we put a probe, we go through the skull and put a probe in the brain, into the part of the brain where we know is causing some of the abnormal tremor, as well as some of the abnormal slowness and stiffness, and giving stimulation in that part of the brain, as kind of in this picture here, can help actually essentially stun the cells and help with the symptoms of Parkinson's. The wire is anchored to the skull, and then it's placed underneath the skin up into a battery pack in the chest, or sometimes the abdomen. And it can help with, in some cases, it can help reduce the amount of medication that you're having. In some cases, it can help control some of the slowness and stiffness and tremor. When this is appropriate for you is dependent on some of the symptoms you're having, and perhaps some of the difficulties you may be having with the medications alone. And your doctor, your neurologist, should be able to kind of tell you when that time frame is, and when to kind of refer you for workup for deep brain stimulation, and whether or not that's appropriate for you. The Duopa is it's a gastrointestinal pump. It's something that gives the levodopa, the main medication for Parkinson's, directly into your intestine. So it involves a surgery, giving what's called a PEG-J tube through your stomach, and then it's attached to a battery pack, and it kind of injects this gel of the medication directly into the intestine for it to be absorbed, and it injects it just at a steady stream over 16 hours. So then you're not taking medications multiple times a day. And that's used to help treat the motor symptoms. And whether or not that is appropriate for you, again, is something that your neurologist can discuss with you. People always ask me, what can I do to help slow down the rate of the progression of Parkinson's disease? And the number one thing that you can do, and the closest thing that we have to slowing down the rate of progression of Parkinson's disease is exercise. There's people that have exercised for a minimum of 2.5 hours a week or 150 minutes, have showed a slower decline in quality of life compared to those who start exercising later. So that is something that's easy that people can do. And people always ask, well, what's the best exercise for me? There's all different types of exercise, and all have been shown to really help with the symptoms of Parkinson's disease. So there's aerobic exercise, there's weight resistance training, there's flexibility and stretching exercise. All of these have been shown to help with the symptoms of Parkinson's. And I would suggest a combination of all of them. But even if it's something as simple as just going for a walk as far as you can, I understand that with Parkinson's, sometimes there's a concern about risk for falls. So just a short amount, as much as you can, that's better than nothing. And then there's, if falls is a big concern for you, there's a large number of different seated exercises that can be done. Follow along online videos that can be done from the comfort of your couch, just watching TV, that can get your heart rate up. I would suggest that just to get some activity in. Yes, the bottom says, do whatever you will stick to and enjoy. People always ask me if, what's the best exercise? Well, the best exercise is the exercise that you will do and stick to. And that can be, like, there's a long list here: biking, running, Tai Chi, yoga, dance, boxing. All of those have been studied in Parkinson's disease, and that helps with the symptoms as well as the mood symptoms, but it can help with the motor symptoms as well. We talked about the different allied health therapies, speech therapy, occupational therapy, and physical therapy. This would be something kind of individualized. It's sometimes nice to have a review, especially with physical therapy, or if, speech therapy, if you have swallowing difficulties, or your voice has difficulties kind of projecting, they can be helpful. Occupational therapy can get really down to the details of what you do on a daily basis that you may need help with in terms of daily tasks. So, in some cases, if I haven't seen a patient, have them reviewed by these therapists in, a couple of years, and I often just say, let's just do a one-time kind of referral and assessment and see if there's anything else that they might suggest, because that can always be helpful as things can change over time. So in terms of quality of life, the mood aspect of Parkinson's disease is often the number one factor that impacts the overall health and well-being of people with Parkinson's disease. So getting mental health support, not just for the person with Parkinson's disease to treat different mood disorders like depression and anxiety, but also caregiver support, because that can be an issue as well. And we understand that often there's any number of scenarios where their spouse is taking care of the person with Parkinson's, or children, adult children that are taking them in, and that can be challenging over time. And there can be caregiver burnout, and our team and social worker can, I would reach out to your social worker and your neurologist about different resources that may be available to you and the caregiver to help prevent deterioration of mental health, because this is more than the motor symptoms. To some people that might be surprising. More than the motor symptoms, the depression and anxiety are what really impact the quality of life. So mental health support, there's many different support groups through the Parkinson's Foundation. You can find that, or a local chapter of different Parkinson's support groups. And then through our social workers, counselors, and therapists, you can reach out and see if there's any resources that can help you with that. There are many challenges with that you need to cope with in terms of Parkinson's. These are just a few, not just for the individual with Parkinson's, but also the loved one and the care partner. Here are some of the things that you might experience and things that you can potentially do. There's unpredictability with the Parkinson's symptoms. They can fluctuate even during a single day. From hour to hour, things can be much different. You know, and it's easy to say just, you know, deal with it, but it does get over with time. It does get better kind of knowing what to expect with the medications as you learn to live with Parkinson's. Sense of control, kind of think about what you can take ownership with. Exercising, these are the things, and drinking more fluids. Those are some things that you can do, making sure that you're not isolated and you're connected socially and trying to still participate in activities and hobbies that you used to do. That would be something that can give you more sense of control, and also touches on the independence and just kind of your lifestyle roles and identity. We've in the clinic here, we often move away from saying, you know, people are not Parkinson's patients. They are people first with Parkinson's. It doesn't define who an individual is, much like somebody can have a knee replacement and people have to make modifications for the knee replacement because they may not necessarily be able to do everything that they were able to do before having knee arthritis and the knee replacement. We think the same about people with Parkinson's. You're the individual first and you happen to have Parkinson's. It doesn't take over everything in your life. You have some things that you cannot necessarily do because of the Parkinson's, but you manage, you do what you want to do, and we give you some medications to help minimize the effect of the Parkinson's on your life. There's always research ongoing with Parkinson's. It plays a vital role in helping us understand Parkinson's. A lot of the new medications that you hear about in Parkinson's are only a result of individuals with Parkinson's. It's only possible because people have volunteered their time and their efforts to take medications in clinical trials or in different surveys or in different ways to help make that a reality and help understand the symptoms and the disease a little bit better. There's a website called clinicaltrials.gov that we often refer people to and just get them to put Parkinson's disease into that, and you can see all the different active clinical trials going on. And this is more for the United States, but sometimes other countries use this as well, depending on where you're listening from. But that's one area that you can go to look for ongoing research. You can also call this number or also look at the Parkinson's Foundation website /research for things that are ongoing. If you're attached to the Parkinson's Foundation Center of Excellence, you can always ask them for ongoing research because there'll be many different studies ongoing at any given time. The PD generation is one that is still ongoing, and many people have participated in that to help better understand, you know, the rate of the 7 most common genetic causes of Parkinson's. So in conclusion, yes, Parkinson's disease has a variety of different symptoms, both motor and non-motor, but they can be treated effectively. So it's important to ask your neurologist and bring up to them, you know, hey, I'm having these symptoms. Are they related to Parkinson's or the medications? Then we can kind of either help you with determining, yes, it's Parkinson's, here's what we can do, or yes, it's a side effect of the medication, here's what we'll do, or no, you should go to your primary care and kind of discuss that further, because that's not typical for Parkinson's. But in order to be able to have somebody that knows what's related to Parkinson's or disease or not, they need to have the right training, and you need to have the right team around you. So finding the right healthcare team and building that and having a point of contact for those questions is very important. Symptoms vary from person to person and can include movement and non-movement symptoms. And like I said, everything is individualized, and personalized treatment is developed. No two people with Parkinson's are exactly the same in terms of what symptoms they have, their rate of progression, what difficulties they're having. So it's important to have somebody that can tailor the treatment to you as an individual. And then, yes, a support network is very helpful for the person with Parkinson's and their families. And I would I would say that that is very much true from what I've seen in the clinic when people have a support network and at least people that they can see and meet. Perhaps other people with Parkinson's that are going through some of the same things. You can share information. Hey, I've tried this. Have you heard about this? Ask your neurologist. That's very important. So with that, I'll finish up the formal lecture part, but then yeah, I'll open up to any questions that anybody has.
All right, well, thank you, Dr. Au. We did receive several questions, and it's pretty well-rounded questions that we've gotten, so I'll go ahead and share that, and I appreciate everybody who has shared them through our Q&A button, so again, we do encourage that. So one of our first questions, how common is Parkinsonism versus Parkinson's disease?
Yeah, so that's a good question. For those who aren't familiar, the term Parkinsonism is just the medical term for a constellation of symptoms. So you heard them before: the resting tremor, slowness, stiffness, balance problems, stooped posture, shuffling while walking. If people have all of those symptoms together, that is what we call Parkinsonism. And that's just the umbrella term for all of those symptoms together. The most common cause of Parkinsonism is Parkinson's disease. Most people that come into our clinic with Parkinsonism, all of those symptoms, have Parkinson's disease, but there are other causes of Parkinsonism. Certain medications that people take, particularly antipsychotic medications, can cause Parkinsonism, and it can look very much like Parkinson's disease, but then we end up reviewing their medications and say, hey, we should come off of this medication, and people often improve once we remove those medications. There's other conditions that are similar to Parkinson's disease that we would call atypical Parkinsonisms, rarer conditions, things like dementia with Lewy bodies, other things, but they often progress a little bit faster, and there's different symptoms that are associated with it. And the list goes on. There's other, strokes can cause Parkinsonism. Different brain tumors can cause Parkinsonism. So when you're asking the question, which is more common, Parkinsonism versus Parkinson's disease, or which is more common, it's a little bit challenging because everybody with Parkinson's disease has Parkinsonism. It's just the name of the symptom. So I would say Parkinsonism is actually more common if you take it that way, because there's many different causes of Parkinsonism, but the majority of Parkinsonism is caused by Parkinson's disease.
Wonderful. Thank you for the explanation. Our second question: I had spinal meningitis when I was 3 months old. Could this have any impact on why I now have Parkinson's?
That's an interesting question. I don't think I would be able to. I haven't heard of any specific cases of that, but I suspect that it wouldn't be related, but I don't know. I mean, there aren't that many people that have both what you had as a child to having Parkinson's disease, and I'm open to kind of hearing more things. But there's many different people that have spinal meningitis or encephalitis or infection in the brain or meningitis at various stages in their life that don't end up developing Parkinson's disease. So I think that in your case, my feeling would be that it would be unrelated and just by chance, because Parkinson's is common, that and we don't know the exact causes of Parkinson's disease, that you just happen to get Parkinson's disease and you may have gotten it without that history of spinal meningitis.
Great. So this one, we've had a various amount of different type of questions, but in general, the question is about the importance of exercise. And so what is the best exercise, and obviously the right amount of exercise to do for Parkinson's disease?
Yeah, so again, it is a little bit individualized depending on what can be safely done. But apart from that, the general targets that I suggest people is 3 to 4 times a week, 30 to 45 minutes per session of you can do all the different types of exercise that we were talking about before, the strength and weight resistance training and the flexibility and the stretching exercises. But often I think aerobic exercise, there's been, at least in terms of the research, that's been one of the ones that is, in terms of slowing the rate of progression, there's been some information from aerobic exercise. So high intensity treadmill exercise is one, or if you can do it safely, I would suggest that, where you get up to 80% of your target heart rate. And it was a small study, but it seemed like the people that did that for, up to 150, 180 minutes a week, they seemed to progress a little bit slower than those that didn't do the same amount of exercise, or were just told to do just whatever exercise that they wanted. So that would be, if you're looking for something to target or a goal to work towards, that would be what I'd suggest. 3 to 4 times a week, 30 to 45 minutes, high intensity aerobic exercise for, and just keep going and keep doing that up to 80% of your target heart rate, depending on your age. But don't neglect the other ones, the flexibility and stretching and the weight resistance and strength training.
Thank you. All right, and so this one also, we had a variety of questions asked, and it's in relation to diet. So how important is gut health related to Parkinson's disease, as well as the impact of diet and whether one should follow a specific type? And are there any specific foods where we can get dopamine? So it's a packed question.
Yeah, so I mean, the gut brain microbiome is something that's being heavily studied right now. And there's some thought that there is a component of, does Parkinson's start in the gut because of the constipation that people experience many years before they develop the Parkinson's symptoms, the typical Parkinson's motor symptoms. There have been a variety of different diets and supplements tried in Parkinson's disease. We do suggest, to be honest, in the clinic, I just suggest a typical well-balanced, healthy diet. There is a type of diet called the MIND diet that we sometimes use in Parkinson's disease. We borrow it from kind of the Alzheimer's disease group, where they take what's called the Mediterranean diet, as well as another diet that's specific for the liver. The Mediterranean diet being more items like a lot of leafy greens, fish oils, nuts, legumes. That can be something that we would sometimes help with cognition. And then, it's overall very, it's a healthy diet that, I suggest for people with Parkinson's. But yeah, I would suggest if you have availability of it, Parkinson's Foundation Center of Excellence dietitian can be a valuable resource in this regard, not just managing the diet in Parkinson's, but also kind of the correlation with what you eat and in relation to the medications and some of the interactions. There was another question about are there specific foods that you can get dopamine from? Yeah, so there are, the name is escaping me, but I think it's like mucuna prurins. There can be some natural forms of dopamine in these. I guess they're beans, but it can be challenging to know exactly how much dopamine you're getting in each of these. So if you do have Parkinson's, and often I just suggest that taking the medications would be the best bet. The reason for that is that you have a defined amount that you're taking and you know when you're taking it, as opposed to, it's not wrong, or, if somebody's taking and eating these beans, you can take them, and just knowing that the amount that you're getting may be small, and it may not necessarily help with, it may not be enough to help with the symptoms, and it varies from dose, from bean to bean, how much you're getting. So just be cautious of that. But for somebody, if somebody had very early mild Parkinson's symptoms and they weren't necessarily bothered by it, they didn't really want to start medications right away, that would be something that, they could take, and I wouldn't have any issues with that.
Wonderful. All right, this one is in relation to medications. So you mentioned sometimes doctors may delay the treatment of Parkinson's. why would that happen? And the second part would be, can you build up a tolerance to the medication?
Yeah. So the delay in treatment is a discussion that's made with the individual themselves. By the time somebody has enough symptoms to have Parkinson's disease and have the clinical diagnosis of Parkinson's disease, the reason to delay would just be if the individual says, you know what, I'm actually able to manage and I don't feel the need to start medication. The physician, from the physician standpoint, if they have enough symptoms, they would start the medication and see if it improves the symptoms. So there wouldn't necessarily be a potential reason unless there's concern for specific side effects. Sometimes with the carbidopa, levodopa, it can cause some nausea and gut side effects. And if somebody comes in and they're very prone to side effects of medications, we might just say, okay, you have mild symptoms, we might pause or hold off, but it really is just to help with the symptoms. So when to start is dependent on the individual in discussion with the doctor. The other question was about, can you build up a tolerance to the medication over time? So this is a question that was actually of debate in the field probably 10, 15, 20 years ago. We really don't see that the medication, your body doesn't build up tolerance over time. So the reason why people think this is, well, in early stages of Parkinson's disease, often we take this medication, the most common medication, carbidopa, levodopa, and you take one tablet 3 times a day. And people do quite well if they have Parkinson's disease for, a year, several years with that same dose of the medication. And then as the symptoms regress, they seem to require more and more medication. And, say 10 to 15 years into the diagnosis, they say, well, look, the medication must not be working because, at the beginning I took 1 tablet 3 times a day and, it controlled all of my symptoms. But now I need to take, my doctor suggested I increase the medication. I take 2 tablets 4 times a day. It must be the medication not working. And over time and through various research studies, it's not so much that the brain is getting used to or the medication's wearing off. It's more so that Parkinson's symptoms progresses over time. And at every stage of the disease, the medications will help with the symptoms of Parkinson's disease. The individual that is 10 to 15 years out will still get benefit from the medication, but it's just that the Parkinson's symptoms have progressed over time that they need more. So there's no reason to delay or hold off on the medications now that we know this, because there's in the past, there were some people that are saying, well, I don't really have too many symptoms right now. I'm going to save the carbidopa, levodopa until later when I really need it. That type of thinking has gone a little bit out of favor because you still get benefit and you don't wear off in terms of the benefit of the medication. And often we want to start you earlier so that you can get control of your symptoms now so that you're not essentially suffering with a lot of symptoms in the early stages when we could have been treating you. So that's the general thought on that.
All right. And, we did have several, but given with time, we're just going to ask our last question here and then close it off. But again, we appreciate the questions that we did receive. So here's for the last one. Are there any research studies you are excited about, like medications trial or genetic studies?
Well, the PD gene has actually been very helpful and very exciting actually in the clinic here. We have some, you don't have to have a family history, but and some people, as we're testing it, we are surprised. Somebody that doesn't have anybody in their family as the first person with Parkinson's disease, and they actually have one of these genetic studies. And I can see the future kind of, there's already ongoing clinical trials with specific genetic mutations. If you have this specific genetic mutation for Parkinson's, they're looking at doing specific treatments for that. And that's kind of where we're headed potentially if in the future, certain medications may not slow down the rate of progression or treat all types of Parkinson's disease unless you have this specific genetic mutation. That's exciting. So it's, getting everybody, all my patients, I'm trying to get them to have this testing done, so that they're aware. So if that were to occur in the future, then they already know which genetic mutation that they have. So that's what I'm excited about.
Wonderful. Well, I appreciate you mentioning about the PD generation, because that's definitely an important campaign that we have here with the Parkinson Foundation. So thank you so much for sharing. So now I'm just gonna do some closing slides real quick, if you don't mind me sharing some of my slides here. And so again, we wanna thank all of you, especially Dr. Au. You make it possible for us to bring these important education programs to our community. And many thanks again to all of you who joined us today. A follow-up email will be sent with a survey. Please tell us what you thought about today's program. You'll also receive a link to today's presentation and additional resources. So again, please join us for upcoming PD Health at Home programs each week for your loved ones and for yourselves, including Mindfulness Monday, Wellness Wednesdays, and Fitness Fridays. And I know there were several questions that we didn't get to, but again, if you have any additional questions and would like to later on the day or later on, you can always reach out to our helpline by calling 1-800-4PD-INFO or emailing helpline@parkinson.org. You can use the same contact info to order our free resources, educational book series, and our hospital safety kit. Again, we want to thank you for joining us, and we hope you enjoyed the program.